Suppose you're a hospitalist called to see a 72-year-old white male who was told by his physician to go to the ER due to quote-unquote abnormal labs. The patient has no spontaneous somatic complaints. You look at the labs which show severe acute kidney injury, severe hyperkalemia, as well as metabolic acidosis. You also look at the EKG, which shows peak T waves. You initiate medical therapy for hyperkalemia, order labs and a renal ultrasound, consult the renal service, and admit the patient to the hospital. How much is this encounter worth? The answer to that question depends upon how you document the visit. This is the note that was generated. It contains 201 words. To see what it's worth, we need to figure out the level of care by taking apart the history, the physical exam, and the medical decision-making, and plugging that information into this table, which shows the documentation requirements for initial hospital care services. For these encounters, all three key components are needed. And we're going to look at the note using both the 95 and 97 guidelines. I'll tell you right from the beginning that multiple mistakes were made in the documentation, which basically doomed this note from the start. First, let's look at the history, which is stratified according to this table, and we'll check it against both the 95 and 97 guidelines. The first thing you notice is a big blank space up here where the chief complaint should be. Every encounter requires a clearly identifiable chief complaint which must be recorded by the physician. Believe it or not, some auditors would try to deny the entire service if no chief complaint is documented. Next, looking at the HPI. Remember, a brief HPI requires 1 to 3 HPI elements, while an extended HPI calls for at least 4 HPI elements or the status of 3 chronic or inactive problems, if using the 97 rules. Let's see what the doctor wrote here. HPI patient is not really sure why he's here. Not a good historian. Apparently, he was called by his doctor and told to come to the ER for abnormal labs. His physician does not see inpatients, so hospitalist service called to evaluate for admission. No spontaneous somatic complaints. Here's a list of the HPI elements, and you might notice that none of them have been included in this HPI. Blaming the patient by calling him a poor historian is not a viable excuse for poor documentation. So an auditor looking at this note would give no credit at all for any level of HPI using either the 1995 or the 1997 guidelines. This is mistake number 2. So how can we fix these mistakes? First, we need a chief complaint. But what about the HPI? Suppose it's true the patient is a poor historian and has no spontaneous somatic complaints. Can we still construct a valid HPI in these circumstances? And the answer is yes. You basically have 2 options. You can either describe the status of 3 chronic or inactive problems, if you're using the 97 guidelines, or you can use the HPI elements to describe the actual history of the present illness, which in this case is renal failure, i.e., we could say HPI. Patient presents with severe acute renal failure diagnosed today in the context of routine outpatient lab draw. Here we clearly document the severity of the problem, the location, the duration, and the context. This adds up to 4 HPI elements, which would allow us to qualify for an extended HPI using either the 95 or the 97 guidelines. But unfortunately, this doctor did not do this, so we're stuck with what he wrote, which leaves us with no valid HPI. The next step is to check the PFSH. Remember, PFSH stands for past medical, family, and social history. Here the doctor starts out pretty well with clearly documented elements of past medical and social history. But he falls apart when he documents the family history because he uses the term non-contributory, which is strictly forbidden. This statement is completely invisible from an E&M coding and documentation standpoint, so he would get no credit for any elements of family history, which is the next major mistake in this note, and leaves us with only 2 out of 3 components of PFSH. This mistake is easily correctable by including an element of family history, which is clinically informative and actually makes sense, like family history is negative for hereditary renal disease. Unfortunately, he did not do this, so we are left with another mistake and 2 out of 3 components of PFSH instead of 3 out of 3. The next step is to check the ROS. Looking at the ROS, he makes another classic but very common blunder by referring to the HPI instead of documenting an actual ROS. This means it's up to the auditor to go back to the HPI to tease out the various elements of ROS, which they may or may not do with varying levels of alacrity. This mistake is compounded by the fact, in this case, that the HPI contains no actual elements of ROS, which means this doctor would not get credit for reviewing any systems whatsoever. So 0 systems reviewed. This mistake is fairly easy to correct by simply taking the time to perform and document the review of systems using the accepted shortcuts. Of course, in these states you can't use the shortcut all other systems reviewed are negative, but everybody else can. Unfortunately, this doctor did not do this, so we are left with no systems reviewed. Looking at the final history, and using both the 1995 and the 1997 E&M guidelines, we see that there is no documented HPI, only 2 out of 3 elements of PFSH, and no systems reviewed. This adds up to no definable history using either the 1995 or the 1997 E&M guidelines. So now for this visit, the first key component of history is covered, or I should say not covered. The next step is to check the physical exam. Looking at the exam, remember we can use either the 95 or the 97 rules. First, let's check the 95 exam, which is based on organ systems and body areas. Here the doctor would get credit for examining the constitutional system. Next, he states HEENT, atraumatic normocephalic, which I guess means you get credit for examining the body area of the head. Next, he listens to the lungs and the heart and does a good GI exam. Then he says extremities, no edema. Technically, you could possibly get credit for examining the 2 lower extremities here, and then neuro non-focal, which would give you the neurologic system. This adds up to 5 organ systems and 2 body areas, which means when using the 95 guidelines, this would qualify for only a detailed physical exam. I think the doctor underachieves on this physical exam simply because of formatting and labeling errors. How can we fix this problem? First thing I would do is get rid of this contraction, HEENT, and break it down into its component parts so you can get credit for examining the eyes and the ears, nose, mouth, and throat. Nothing wrong with the respiratory exam or the cardiovascular exam or the GI exam. The extremities is kind of tough. I would relabel that musculoskeletal and focus on the digits and look for clubbing. The neuro section is fine and would give us credit for examining the neurologic system. This would add up to 8 organ systems, which would give us credit for not a detailed exam, but a comprehensive exam using the 95 E&M guidelines. Unfortunately, this is not how the doctor formatted his exam, so he would still only get credit for the detailed physical exam. Let's see how the 97 rules would add up the physical exam. Looking at the 97 exam, the level is based on the number of bullets examined within the organ systems. Here the doctor would get credit for 2 constitutional bullets by commenting on the patient's general appearance and also recording 3 vital signs. I don't think he'd get any bullets for saying atraumatic normocephalic, 1 bullet for listening to the lungs, 1 for listening to the heart, 1 bullet for a brief abdominal exam and 1 for assessing the liver and spleen, maybe 1 cardiovascular bullet for looking at the lower extremities for edema, and 1 neurologic bullet if you consider non-focal to mean no sensory deficits. This adds up to 8 bullets, which means using the 97 rules, we would only get credit for an EPF exam. So remember, we have no history recorded using the 97 rules, and now we know we only have an EPF exam, which is also not on the chart for this type of encounter. But remember, the 1995 guidelines gave us a detailed physical exam, which puts us here on the chart. When this happens, an auditor is instructed to use the guidelines which are most favorable to the physician. So in this case, we would use the 95 rules and go with the detailed exam. The next step is to check the medical decision-making. Looking at the medical decision-making and starting with the problem points, here we have a new problem of renal failure for which further workup is described, which means this problem is worth 4 problem points. Next, we have a bunch of other problems which are also new, but no further workup is described. For these problems, there's a maximum of 1 per encounter. This adds up to a total of 7 problem points for this encounter. The next step is to check the data points. Looking at the data points, here we did review labs, and we also eyeballed the EKG, which adds up to a total of 3 data points. The next step is to check the risk. Looking at the risk, the operative part of the risk table is the high risk part, because we have a patient with acute renal failure, which qualifies as an acute or chronic illness which may pose a threat to life or bodily function. So it's definitely a high-risk encounter. So we have 4 more problem points, 3 data points, and high risk, which means that since only 2 out of 3 dimensions are needed, this adds up to high-complexity medical decision-making. So looking at the documentation as currently written, here's how it turns out. Remember, we're using the 1995 guidelines to determine the level of care because the exam works out better for the doctor using these rules as opposed to the 97 guidelines. Here we have no history, a detailed exam, and high-complexity medical decision-making. The problem is that admission H&Ps require qualifying documentation of all 3 key components for any given level of care. In this case, since we have no valid history recorded, we cannot qualify for any level of care. This is known as falling through the floor and occurs when the documentation does not support even the lowest level of care for any given encounter. When this happens, you should drop down to the next lowest type of service, in this case a hospital progress note, and retest the documentation. So here we still have no history, a detailed exam, and high complexity medical decision-making. For these encounters, only 2 out of 3 key components are needed, so we would qualify for the 99233 level of care, otherwise known as a level 3 hospital progress note. So here the doctor performed services for the patient consistent with a high-intensity H&P, but can only bill for a hospital progress note because of multiple documentation errors. So let this be a lesson to you. The current documentation would qualify only for a level 3 progress note. It contains 201 words, but is only worth $96. This works out to about 48 cents per word. On the other hand, making the slight corrections which we made to fix the errors, the document would qualify for level 3 H&P. This contains 203 words, or only 2 more words than the original document, but the reimbursement is $194. So by adding just 2 words to the documentation, you double your productivity. So again, it's not the quantity of the documentation that's important, it's the quality. So avoid these errors. Thank you. If you want to learn how to take apart your friend's notes like this, consider signing up for one of our web-based E&M coding curriculums. We offer several different subscription options to match any practice pattern. We also have a coder curriculum which includes up to 33 AAPC CEUs for only $99. If you need E&M coding for multiple providers, ask about an E&M compliance web portal which provides trackable and verifiable E&M education for multiple doctors.